will go ahead and get started, everyone. My name is Jackie Rao. I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. Sorry for not having my video on. For some reason, Zoom is telling me that I need to select another camera, but this is the only one that I have. So not sure what to do about that. So I apologize. So thank you all so much for joining us today. For our agenda, we're going to start with a really brief review of the MCT2D coverage resources, just so that you're aware of the things that we've developed for the collaborative, not necessarily related directly to prior authorization, but focusing on coverage in general and helping patients and you determine the best coverage for them. We are going to go over the new prior authorization law and have someone from Michigan State Medical Society here to talk us through that and answer any questions that we have. We will then begin with an overview of the prior auth processes at each panelist's office and take a look at the pre-submitted questions and live questions from the audience after that. Let me see. Are you guys having trouble with audio too? I know I got one message that my audio is not great. Is that the same for others?
I can hear you, Jackie.
Okay, and it sounds all right?
You sound great.
Okay, so I'm sorry, Rebecca, I'm not sure what to do about that. I think I guess if everyone on the panel, well, everyone is muted, so that was my only idea. Okay, so to take a brief look at some of the tools that we've created in the past, and these are all linked, and we'll send out the PowerPoint afterwards to everyone too, so that you can access them easily. This is just an overview of some of the tools that we've created. The most recent and newer ones are related to the insurance coverage worksheets that we've created for patients. So this is where we have the provider fill out the top part, like maybe you're recommending a GLP-1 for the patient, and then the patient calls the insurance company and asks these questions that we've laid out here so that they have a good understanding of what to expect. So know about their deductible, what is it, how much is the met, what's my preferred pharmacy, are the medications I'm on preferred, are there GLP-1s in the example that I gave that are preferred by the insurance company. This is both printable and editable as a PDF, asking about the copay, 90-day supply, is it from local pharmacy, mail order pharmacy, so that there's no surprises on the patient end once we submit these scripts. So then there's the same thing for CGMs. There's information on like some of the insurance lingo for patients too. So we're hoping that this takes off a little bit of the onus on you as the practices trying to determine all this information and gives patients some of the tools and resources that they need to get these answers for themselves. Also, Dr. Ashwin, can I ask that you monitor the chat too and the questions and let me know?
Yeah, I am.
Perfect. Thank you. Great. And so the next thing we have on here is like a toolkit on costing coverage. That's just a little bit expanded on what we just showed. So it has the document that we shared, affording your diabetes treatment, medication copay cards, patient assistance programs for Medicare Part D, and senior savings programs for Medicare Part D. So really just more of a booklet feature approach for patients on these types of things. So circling back here, we have the Anti-Obesity Medication Coverage Guide, and that is a newer resource that we've created too, similar to our coverage on SGLT2s, GLPs, the CGMs around the anti-obesity medication. So Medicaid has good coverage on these for prior authorization, otherwise not too strongly covered by commercial insurance, but this should give you some overview into what is and isn't covered. Then we have our more general one, which I think most people on this call will have seen previously around just our general coverage. We update this quarterly. We just last week went through and added some new updates. They aren't live yet, but we will continue to update this on a quarterly basis or when we know of changes. Okay, cool. So the last one we have is just this Medicare Part D patient assistance programs that we touched on in the past. And where did I save this one? Haha. Okay, here's all like the copay cards and things like that for patients on Medicare Part D. We have a different resource for patients on commercial insurance. And so those are available on our website too. So just a brief overview of the kind of tools and resources we've created. If there's things that you need that we don't have, let us know. And next, we might need to fix something really quickly because our panelists for this changed, and I'm not sure we had them as a panelist. So Kate, can you confirm maybe via the chat or Q&A that you're on the call, and we'll get you added as a panelist? Let's see.
Jackie, I think I just moved her as
Okay, great. Hi, Kate. Can you hear us?
Connie's here as on voice only on the phone. I wasn't able to access via online, so I don't know why.
Okay, no problem. That's perfect. Okay, hi, Kate. Thank you so much for joining us today to talk about the new prior authorization law. I really appreciate it.
Absolutely. I'm happy to be here. Thanks for letting me sub in for Scott at the last minute. I know he wanted to attend and then had some other things come up that he needed to take care of. So I'm subbing in for the prior auth expert here. But quick overviews, I'm not sure like how much everyone really followed this throughout the process. It was about 3.5 years that the Health Can't Wait Coalition worked on getting this legislation through, with many roller coaster rides in that time. But broad strokes, this was really focused on improving the prior auth process to make it a lot more streamlined, more transparent, based on all clinically valid decision-making guidelines, evidence-based, and much more timely, hopefully. So there are now some just guardrails where there weren't any before. For urgent requests, for example, the insurers will have 72 hours to respond. If they fail to act, then the prior authorization is now considered granted after 72 hours. For non-urgent, it will be considered granted within 9 calendar days. They did go back and forth on some of those different timelines, but ultimately settled on those to try and bypass that sometime confusion of, well, it was a Friday that I submitted it. Will this be granted on Monday, or are we not counting those days? So using the 72 hours specifically for the urgent request was to try and help make that a little bit more clear. One of the exciting things about this is that it also requires insurers to create sort of a gold carding process. So what that would be is if a physician office or practice regularly meets certain benchmarks, is clearly not abusing the process, not over ordering things, only ordering clinically acceptable treatments and tests, then that office will be able to sort of sidestep the prior authorization process, and those should simply be considered granted. Probably there would be some on the physician's part having to check in or do spot checks on maybe a yearly basis. That is not fully defined in the law. That will be kind of created through each insurer, which is a little bit tricky because there could be different processes based on the different insurers, but is hopefully ultimately going to make the biggest difference in terms of getting some of these really more basic requests not clogging up the system and just out of the way a lot faster. So those are very broad strokes of what this new law will do. It is being implemented on sort of a delayed schedule to have time for the insurers to come up with those processes, create their forms, things like that. So I believe the first sort of step of implementing the law is June 1st of 2023. So it's still a little ways to go, but is hopefully gonna, once it gets off the ground running, gonna make a really big difference in getting these things a lot faster. Any questions, anything I can do? I'm sure I missed things.
Thanks so much for that, Kate. Please, anyone submit any questions that you have about the new prior auth law via the Q&A, and we'll make sure to get them answered.
So Kate, if you can stay on the call with us and we get questions, maybe we can just respond to them in the panelist answering our chat.
Absolutely, no problem. Okay, perfect. Thank you so much, Kate, for that overview. Really appreciate it. Okay, so next we're going to switch over to our panelists who are all here today. We have Theresa Gallagher, who is a nurse, a care manager from Great Lakes PO. We have Bobby Dabicci, who's a PharmD from Lakeland. Tiffini Jones, who is a nurse and a diabetes educator from GMP Network. Renea Clark, who's a practice coordinator and quality support specialist from LPO. Heather Keifer, who is a dietitian and diabetes educator from Holland, and Connie McDonald, who is a nurse care manager from St. Mary's PHO. So we were going to start by having each person just go ahead and give a high-level overview of the prior authorization process at each of their offices or the offices that they work in. If any of you have slides that you want to share, just let me know and I can give you sharing rights or pull them up from you. But if not, we can go ahead and start with you, Theresa, and then just go down the list.
I don't have any slides. I'm Theresa Gallagher. I'm a registered nurse, care manager at Riverview Medical in Bay City. We have 5 providers. We have 2 RNs, and then we have 3 medical assistants. Prior auths are done by the registered nurses in our office. We generally use electronic forms as much as we can, like Cover My Meds, or other payers have different portals, but we use Cover My Meds. It can be a burdensome process. For the most part, we have it pretty streamlined. We just kind of work together to get them done as much as we can. As you do them, you kind of learn what the questions that they're going to ask. So, but it just depends on how many roll in each day and what the medication is, how burdensome they are.
Perfect. Thanks, Theresa. Bobby, do you want to go ahead?
I'm Bobby. I'm the pharmacist at the Lakeland offices, and each office around me seems to do it a little bit differently. The 2 main offices I spend the most time in, I'll talk about a little bit. In one of them, they have just one person who does all the PAs for the whole office, and I believe there are 8 providers there prescribing. So they feel like they do get bogged down a lot. It's a medical assistant. But she knows the process pretty well. And then in the other office I'm in, it's each provider's individual MA who will go through it. In all these cases, they are trying to use electronic as much as they can as well. But that's how they do it in each of the offices that I'm in.
All right, great. Thanks, Bobby. Do you want to go ahead, Tiffini? If you're talking, you might be muted. Yeah.
Sorry.
No worries.
Hello, everyone. I'm a nurse care manager with GMP Network. And what I was going to speak about is my previous practice. So I was a nurse and a care manager of a primary care practice for a long time. And the process we used for prior auths was when we could, having a dedicated person to do the prior auths, using Cover My Meds, as Theresa said. And then we created a spreadsheet, just an Excel worksheet that it was a shared document, and each year or each time a formulary changed, we kind of put the most common drugs, the most common payers, and did a review with our providers, see which medications they prescribe the most. And it was just an active document that was just shared across the board and everybody could look at it. That really, really helped. And then just training everyone on where to find that document. And I thought that was really, really helpful. And again, just kind of looking at each payers and trying to keep up as you can, and maybe having, 2 people in charge of prior auths when you can is really helpful. Thank you.
Great. Thanks so much, Tiffini. Renea, do you want to go ahead?
Hi, I'm Renee, and I am the practice coordinator at LPO, but I'm also the office manager for one of our PCP offices, We have a small office with 2 providers, 2 front staffs, and myself. So I actually do all of the prior auths, as well doing Cover My Med for most of them. And really just streamlining basically what some of the others had said, learning the insurances and working with the providers to get those done quickly.
All right, great. Thanks so much, Renee. All right, Heather, do you want to go ahead?
Yes, my name is Heather Keifer, Diabetes Education at Internal Medicine North and Peds and Internal Medicine through the Holland Hospital Medical Groups organization. And we are quite fortunate in that we have like a centralized team of 3 medical assistants that sit off-site or like off clinical site in an administrative building. And they take care of all prior auths for all of our medical group offices. So 3 full-time medical assistants covering roughly 40 providers, 40,000 patients as far as patient panel. And then just on average, they're able to process anywhere from 175 to 200 medical prior auths each month. And so they have a great streamlined protocol with follow-up and communication with the pharmacy. That team of 3 medical assistants basically do everything from start to finish, with the exception of calling the patient. So the office will then call the patient once a decision is made, but our PA team will actually call the pharmacy to let them know whether it was approved or denied. We'll routinely follow up, we'll help with appeals, and they do get support from the clinical staff here in the office if needed, as well as we have 2 pharmacists that cover all of those medical groups as well. And they are used as a resource anytime there's a denial. And so kind of answer any detailed questions that folks have later in today's conversation, but that is mainly how our medication prior auths are dealt with. And all of our continuous glucose monitor prior auths go through myself or our diabetes educators at the practice level at this time.
All right, great. Thank you. Sounds like you guys have a really robust system for addressing that. So it'll be great to hear from you later on with how you operationalize some of that. All right, and last but not least, Connie, do you want to go ahead and get an overview of yours?
Hi, yes, thank you. I am Connie McDonald, Care Manager, RN, and I work with Ascension Medical Group. That's St. Mary's PHO. I work actually in 3 different physician offices. In Saginaw, I work with 2 physicians, and the MAs do the prior auths. Of course, I help with that as well. At Bay City, I have 2 providers and a physician assistant also, and the MAs there also do the prior auths with some assistance from myself. And then in Birch Run, I have 1 physician, 2 nurse practitioners, and currently they actually do have a referral specialist, which is awesome. And they go through different processes, which we can talk about going forward.
Okay, great. Thank you all so much for that high-level overview. And what we're going to do now is get into some of the pre-submitted questions. So when you were able to register for this meeting, there was an option to send any questions that you had ahead of time. So we have about 8 of those, and then we're going to go ahead and open it up for you to submit anything via the Q&A and have our panelists answer it. So we did have the panelists sign up for answering each of these questions. And so the first one is, do you have any tips for other offices trying to improve their prior authorization procedures? And we're going to have Heather and Tiffini speak to this question. So whoever you would like to start, go ahead.
I'll start. So yeah, basically trying to find out what your common improving is, starting with your common drugs, which medications are, requiring the most authorizations, and kind of streamlining that. Again, that small working document really helps. It's a spreadsheet, and you can, update it as you go, and it really kind of just opens it for the provider level, where they can see if their medication is going to require a prior auth at the time of writing it, and then they can notify the patient as well. And then there's also an app called Coverage that you could put on Apple iPhone or iPad, and that helps as well. So that did improve our prior authorization procedure to make it a little easier up front.
Okay, great. Thanks so much, Tiffini.
You're welcome.
I guess from our standpoint, it was very helpful when our pharmacists started getting involved about, I'd say roughly a year and a half ago. Upon any denial before appeal, it's sent to the pharmacist to review to see if an alternative therapy could be used or like a comparable alternative. And then in addition to that, for our continuous glucose monitors, we do utilize Parachute heavily now, and it does speed up the process quite a bit. And we're able to get feedback whether the durable medical equipment company can service the patient or not, and move referrals a little bit more easily than before. And so that's been really nice. And that's probably, we've made that transition in these offices probably in the last 6 to 8 months, really more leaning on that Parachute. When we do have to fill out a paper continuous glucose monitor prior auth, we tend to use like the pre-scripted, a lot of our patients here are Medicare, but Medicare criteria, and go ahead and amend the physician's notes with that criteria spelled out. And that seems to get the chart notes through and meet that criteria a lot quicker than what we were doing previously.
Okay, great. Thanks so much, Heather. Can you talk a little bit about what Parachute is, just in case there's anyone on the call who's unaware, like how it functions, how it's helped you?
Yeah, sorry about that. So Parachute, from what I understand, is a platform that's going to allow you to electronically prescribe like various pump supplies, as well as continuous glucose monitors, and I think even testing supplies to like 20, I think we have 20 different DMEs listed in our homepage. And so we're able to send those referrals electronically, and you're actually able to build out your chart notes as you're sending the referral, which helps and digitally sign on behalf of the provider if they're in agreement of that. And so it just speeds things up a little bit from that perspective, rather than hunting down chart notes, amending them to make sure that they've listed out clearly all the different criteria, and then getting a wet signature for the letter of medical necessity. And so it just speeds things up a lot from that perspective. And so it's an online platform.
Okay, great. Thanks so much, Heather. Okay, our second pre-submitted question was, do you have tips for smaller offices on how to handle prior authorizations? And Connie and Renea were going to answer this question.
I can go. Are you ready?
No, go ahead.
Okay, thank you. One thing that I did find, and of course that kind of comes on the back of what the prior panelist said, was the Parachute. I actually just recently discovered that process, and that's awesome. It's a big boon, and it certainly is going to help, I think, the authorization process and our patients being able to get the CGMs. That's going to be fabulous. And I've had one work with them so far. So of course I am still new at this, but the interesting thing was, it was probably one of the best processes that I have come across in all of my other prior auth experience, in that I went through the process on Friday, and this morning I got all the information that it was approved and that it was being sent to their sister company, diabetic supplier, to be filled. So that's pretty, I mean, 2 business days, actually less, right? So that's pretty phenomenal. So I think, that being said, the promise in that is that we can do this better, and it can be done better. So that we're pursuing that is definitely very, very doable and commendable that we can pursue that. Some of the other sites that we use, of course, is Cover My Med, which everybody's familiar with, and that kind of comes with some promise. It is helpful, but then it also can become complicated as well. Other prior auths get submitted to RADMD, and that's more for studies and procedures, and that seems to be long in approving. So a lot of the processes that we do right now are just, it's difficulty and time in getting things done, getting things approved, and it's a constant having to look back, you know, and making sure that things are going as they should. Some of the processes we use, the MAs are constantly, you know, are always trying to put through auths as they have opportunity to do so. And I think overall, there's just a lot of things that can be improved. One part of the question is what can we do to improve? Well, there's like time is a big thing, and the other part is trying to figure out. For example, I spent 68 minutes just to get Lantus through for a patient, and I don't understand that. I'm relatively new at trying to do prior auths, but again, because I see the significance of this and what experience I do have, I really wanted to participate, talk about some of the difficulties, and but again, I have found Parachute, which I find promising, which tells me that we can get processes in place that can be extraordinarily streamlined and get the job done in a timely way. Availity is another site that we use, but that right now doesn't have a lot of insurances on it, so you still have to go through a lot of different multiple sites to get things approved. Blue Cross Network, Blue Cross Blue Shield, and HAP are the easiest insurances to get the prior auths on, you know, per our processes right now. And I think a big issue is communication with the companies and the different online website support that we're trying to streamline these process through. Communication seems to be difficult. Again, I think it's hopeful that within offices, as we find new process, and not even so much new process, but improving on the ones that we have in place. And also I find that having a referral specialist is extraordinarily helpful. It really does streamline the work, and it does focus the work. Again, a lot of the difficulties I've described are even encountered by the referral specialist. I only have that at one office, but again, the MA's attention isn't diverted. They can focus on what they need to focus on, and certainly timely patient communications is a little more effective having a referral specialist. So I don't know how helpful it was as far as tips for practice, but.
No, that's great. Thank you, Connie. Can I go ahead, Renee? Mm-hmm.
Yeah, and I'll say communication I think is key too, but I find for us in a really small office, communication with the patients is also really key, because they're instantly upset with the provider's office when they go to pick up their prescription and they can't pick it up because the provider hasn't done what they're supposed to do. So in our office, as soon as something comes in from Cover My Meds, typically how it works, I try really hard just to work on it immediately and instantly let the patient know. We have secure text messaging, and just sending them a quick message that we recognize we need to do a prior authorization. We're on it. We'll let them know as soon as we hear. And that has seemed to really help less calls to this. Another point key is really communicating the chart where I'm at, so that if a patient does call the office, any staff that answers the phone can quickly answer that and lets the patient know that we're on top of it. Not, I have no idea, let me check, we'll call you back. So that has been, that's really helped in our office. Also learning the patterns of my providers. My providers prescribe different medications, and learning which medications I'm going to be working on for them, and then having them know what questions I'm getting back from the insurance company. So they can just learn to have that information in the chart. So I can get the prior authorization done much quicker for them.
Okay, great. Thanks, Renee.
And as we move on, Jackie, to the next question, there's some Q&As that I've kind of answered preliminarily, but we'll bring them back up after we finish our pre-submitted questions. So panelists, take a look while you're waiting.
Thanks, Dr. Ashman. Okay, our next pre-submitted question was, do you use any software that helps with your prior authorization submissions? And we had Theresa and Tiffini answering this question. Theresa, if you want to go ahead.
Yeah, similar to what you've already heard, we use Cover My Meds. We also use Parachute. I find both of the websites very helpful. Parachute is life-changing. If you're not on it, I think that everybody should be on it, especially for any kind of Medicare supply that your patient needs. We've done INR machines through there. We've done everything. So it's been a great resource. And like one of the panelists said, like you get a turnaround time. So I've had them come back the same day. Like I started in the morning and it was approved later in the afternoon. So it's been a great, but really those are the two main ones we use. There are, Availity was mentioned. I've used that. There's some other payers that have specific portals that they want you to use. So I have used a little bit of that, but pretty much everything can go through Cover My Meds. And Parachute is just for Medicare patients. From what I understand, I've not tried to do a commercial patient on there only because I was told it was only for Medicare. But those are kind of what we're using in our office.
Okay, great. Thanks, Theresa. Tiffini, do you want to go ahead?
Perfect. Almost exactly like Theresa said. So Cover My Meds is a go-to because you can look at it right there when you put in the auth or request and, kind of see what criteria, if any, that the patient may not meet. And then again, using that coverage app for the providers to use on their iPhones or an iPad, and they can base it on payer, by state, even Medicaid, and see if that's going to require a prior auth and let the patient know, like another panelist said, before they leave, so they know that we are aware, and that try to limit some of that conflict where the patient's upset or going to the pharmacy. We kind of can find out up front.
Mm-hmm. Great, makes sense. Thanks, Tiffini. And just to clarify a comment that we got in the Q&A, so Parachute is not for medications, as Mary, you pointed out. That is for DME only. And then it sounds like Cover My Meds is the one that you guys use. Is it Cover My Meds? Sorry, for medication. So it sounds like kind of for at least it goes this collaborative around CGMs and the medications. You would need both. Mm-hmm. Okay. So moving on to our next question, is the prior authorization person in your practice able to identify and suggest alternatives that will not require prior authorization? And Bobby and Renee, we're going to answer this question. If you want to go ahead, Bobby. Mm-hmm.
Thank you. So one of the reasons I kind of wanted to answer this question is because in the two offices I'm in, they do it differently. And in one office, the MA does the PA for their provider. They match one-to-one basically. And when they get a PA, they don't try to identify an alternative. And I tried to work with them on that some, but they felt that it was not in their role, not that they didn't want to do the work, they're hard workers, but they felt like it was outside of their scope of practice to be recommending, as they were seeing it, a different medication. And I was trying to talk to them about how it's still going through the provider. You're just letting the provider know that within that class, this one is more likely to go through. But it was a little bit hard to get that message across. In my other office, where one person covers all of the providers, she does try to use a number of different tools. I showed her the coverage app that Tiffini talked about. She likes that. The MCT2D tools are really, really great for showing people. And then she also knows how to pull up formularies and everything. Tries to keep a working document of those. Of course, as one of the other panelists mentioned, they do change, which makes it difficult. But I find that the office where the medical assistant feels empowered to suggest to the provider within this class of medications, this is the one that's more likely to be covered, and then going to them with that, instead of just spending time on a PA that's fairly likely to get denied. That works a lot better for that office.
Great, thanks so much, Bobby. Renee, do you want to go ahead?
Yeah, some of the suggestions I would have, I've learned over time to save in my favorites the templates or the formularies for our insurances that we have the most patients in. And then hitting control find and typing in the medication that I got the PA on, just to see what other medications in that class are covered. And then I'll print that specific page and ask the provider if there's something else that is in a tier 1 that they could prescribe, or if there's not, they'll let me know which ones they've had in the past. So it helps me when I am doing the prior authorization, but quickly getting to those formularies has been a time saver.
Right, great, thanks so much, Renee. Okay. Our next question, so do you ever have issues with what the pharmacy enters into the day's supply for a prescription? Since as you've seen, like on the coverage tool that we have and other places, there's a lot of quantity limits on these medications, and if the days that are entered surpass that, it may lead to a prior authorization that wouldn't otherwise have been triggered by the medication. So Theresa and Tiffini, we're going to speak to that. Theresa, if you want to start.
Sure. We've definitely run into this. I unfortunately, I don't really have a fix for it. Sometimes on Cover My Meds, when you pull up, you can notice the issue right away because it'll say the medication, it'll say whatever quantity the pharmacy put in. So sometimes you notice right away that they put the quantity in incorrectly, but other times you just have to do the prior auth and wait for the letter to come back to say, hey, this is covered. It's covered for 28 days or whatever the supply issue is. At least that's what we do at this office.
I agree. There's really no easy way. Again, looking in Cover My Meds, you can sometimes find that, and having the formulary or those cheat sheets available. But unfortunately, sometimes, you can tell on your end that there's a quantity limit, and you know that when the provider writes it. However, sometimes it's a call to the pharmacy to find out, by looking at it like, okay, this drug should be covered. Why does it need a prior auth? Looking at that, the formulary for that payer, and then going right to the pharmacist sometimes is, but again, it's still very time consuming. But Cover My Meds, sometimes when that key code, when you enter that into the pharmacy or into Cover My Meds, you can see how the pharmacy is running it. And that usually kind of gives you a key to contact the pharmacy and see if you can work around it before going to through the whole prior auth process and finding that's the actual problem.
Thanks, Tiffini.
Thank you.
Okay, 3 more questions that we have pre-submitted, and then we'll look to the ones in the Q&A and others that have been submitted. So do you have any data to support the use of a central referral person as opposed to each provider support person doing referrals around like rates of approval, the time it takes, et cetera? And Heather was going to speak to that for us.
Yeah, so I went over a little bit in the initial overview, our system, but right now we have 3 medical assistants that cover all 40 providers in our medical groups in Holland here. So roughly 40,000 patients. And I just want to point out that they do additional tasks in addition to the prior auth. So when I reached out to the person that oversees that program, some of the other tasks that they do would include all of our outgoing referrals to specialty care. So they're going to be printing those chart notes. So they are doing some additional tasks. So I'm not certain that full FTE would be required to cover those amount of providers if that's all they're doing. But they also try to optimize and not waste time with completing these prior auths that are just going to be denied. So one way they do that through their through their system is that they use the Fingertip Formulary. And I don't know if anybody else is familiar with that, but that is the formulary that they like to use the most, or they find the most accurate. And based on what I've heard from our pharmacist, is that if a drug is not listed on the patient's formulary, there's a very low chance that that drug is going to be approved even with a prior auth. And so that's where we've been trying as a system to stop prior auths before, really eating up a lot of time if we know with pretty good certainty that the drug is going to be denied. And from there, look for comparable alternatives on the formulary. And usually those alternatives get sent back to the provider and myself based on, or from our pharmacist. And so I would say that is, we find this system very efficient. When patients call in to the office, we're able to open our medical record and, we can see that there's a prior auth that's pending, and we can give the patient an immediate update based on what our prior auth team has notated. We can let them know when they're planning to follow up next, and all of that's documented in one central location. So I find that really helpful to reassure patients. Like somebody had said earlier, they're processing the prior auth that was submitted on this day, and they will be circling back on this day with your insurance. And so we find it really helpful in our system. And I know our medical assistants do in the offices as well, as it would be quite a time some burden.
All right, great. Thank you so much, Heather. Whoops. So our next question is, can you review how to get SGLT2s and GLP-1s paid for by insurances? And Bobby and Theresa, we're going to speak to this. If you want to go ahead, Bobby.
Thank you. So for this one, I think that the chart notes are really important. So I do try to let my providers know that when they're prescribing one of the medications in this class, that they note the metformin status, whether a patient's currently taking metformin or a patient failed metformin. And that can go a long way to getting a lot of these through if you have to do them. Other than that, I spend a lot of the time trying to avoid doing them in the first place if they're not needed, which I think Heather was speaking to a little bit too, using the tools to see if a PA would even be expected, and then providing the doctor with the medications that are covered instead. And then also looking for other opportunities to help the patients out, and kind of two birds with one stone. So there's a lot of my patients who will do the patient assistance programs for, and then you don't need the PA in the first place. And yes, it's a different kind of paperwork, but it also can save the patient a lot of money if they're eligible for that. And a lot more people are eligible for it than you would think. The income gaps are limits are a lot higher than you would think. Another thing I wanted to mention was that when these PA requests come in, I know that a lot of them are auto-generated from the pharmacy. So somebody has mentioned about the day supply. And so if it comes into the pharmacy and they enter it for the 30-day supply, it's supposed to be a 28, a PA gets shot off to our teams. And then depending on the level of skill of the technician on the pharmacy side, a lot of times they're just noticing that and saying, oh, this should be 28 days. And then they fix it. And then you call or somebody on your team calls, and then they're like, yeah, that's been done for a while. And there's not always a great way to avoid that. Again, what I like to do is look to see if the PA would even be expected in the first place. And then one other note, I guess I would say, is the difference between not covered requires prior authorization versus expensive due to like a coverage gap donut hole. I get a lot of messages from providers saying, hey, can you make a recommendation? This medication's, they're not saying go to a different class. They're saying it looks like this isn't covered, but it was covered, and every expensive medication is going to be more expensive. So just kind of making sure that the members in the office are kind of aware of the differences there, because trying to do a PA is not going to fix that problem. And then that's a great time to look at patient assistance program as well. Unfortunately, I don't have a great solution for getting these just plain covered if you're getting failures, other than making sure that the med history is in there, metformin specifically being the big one. And asking the doctors to do it so your person doing the PA doesn't have to dive way back in the notes and try to find that spot where it was written.
Mm-hmm.
So, thank you.
Yeah, that's great. Thanks so much, Bobby. Theresa, do you want to go ahead?
I don't have really much to add. I think you did a great job. That's pretty much, and the metformin failure is really the most important. piece of the SGLT2s and GLP-1s and getting them covered. There has to be a metformin failure. You need to find it. Most of the providers here know that it needs to be. They try to put it in that note when they prescribe it so that we have that information for the prior auth. And then expense, worrying about the especially the Medicare population, that donut hole. We do a lot of patient assistance as well. So, and then we're also using the sheets that were created by MCT2D. Those have been very helpful just to stay with whatever SGL2 is covered by whatever payer, and not prescribing a Farxiga when Invokana is covered and vice versa. So yeah, that's what we're doing. Thank you.
Great. And then our last pre-submitted question was similar to the last one around advice for getting CGMs covered through prior authorization. And we were going to have Tiffini, Heather, and Connie respond to that. Tiffini, if you want to go ahead.
So yeah, for this, I would just say seeing who the patient goes through for their prescriptions and who their pharmacy is through. Obviously with Medicare, it's considered DME, but Blue Cross, you can get that through the pharmacy. So finding that out, this way you're not sending it to a DME, sending it back to the pharmacy, just like almost every panelist said. Just figuring out first, is the patient even going to use it? Are they going to, use it, wear it? If you can get in contact with some of the, companies and getting samples, that's another good area. I've seen where we've gotten them approved, did all the work, and then the patient didn't like it or had a reaction to the adhesive, different things like that. I think that does help. But as far as getting it covered, like everyone else said, documentation's key. Documenting it, doing it once, and then, writing out so people know where it was, where you left off and where it was last sent. I think those really help.
Perfect.
Thank you.
Thanks, Tiffini. Heather, do you want to go ahead and describe your approach to this?
Sure. So just to build off of what Tiffini was just saying, we are fortunate enough to have samples or patient experience kits in the office, and it is really helpful to have a patient try the equipment out before ordering it, because I would say 98% of the time they love it, but every once in a while they have a skin allergy, or there's a barrier that they don't want to move forward, or they want to move forward with a different product. And so that's really helpful. But then also taking that time when we're trialing the product to thoroughly explain to the patient expectations. So explaining to our Medicare patients that this is something they're going to have to get in the mail, and the criteria for them to get the product. If they don't meet criteria, we don't submit those referrals to a DME if they're not on insulin, for example. And so then explaining to them the out-of-pocket expense, the cash options, and using GoodRx, Single Care, or Michigan Rx cards. I will say one of the bigger hurdles is that these patients will then call in for refills a lot of times, and sometimes staff will send those refills through from their med list through to pharmacy, which generates a prior auth. But luckily those come back to me. And so I'm able to quickly just disregard a note, not needed, patient filling through durable medical equipment company. And so that's a hurdle that we're working through right now. Like I said, the template with the Medicare criteria and Medicaid criteria that can easily be amended into notes is key here. And then also the Parachute platform that we've had success with recently. In electronically referring those patients. But those would be the two big things, is just being open with patients, letting them know when they're likely not going to have coverage if they're not on insulin, and then giving them an expectation of cost so that they know whether or not they would like to continue on with this product after they're able to weigh the benefits and after trialing it.
Okay. Thank you so much. And then Connie, is there anything you'd like to add?
Yeah, I think Tiffini and Heather both kind of covered the points that I would have spoke to. Again, though, I would like to reinforce using Parachute for the CGMs, especially for the Medicare population, because they are just truly, my experience was just extraordinary and very, 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 very helpful. And of course, the templates that we get through CMT2D have really been a big boost to help and to kind of coalesce all the knowledge and what we need, going forward to try to make this more streamlined.
Great. Thank you so much. And that's the end of our pre-submitted questions. Thank you so much to all our panelists for answering those and the work that you put into this so far. I'm going to hand it over to Dr. Ashman, who's been monitoring the Q&A a little more closely than I have, so that she can bring forward the Q&A questions that she would like you to answer to, and we'll just open it up. Any of you that want to jump in and give an answer, that would be great.
Terrific. And I just want to thank you all. This has been so helpful. And I think the reason that we want to spotlight and highlight our members is that you're doing such terrific work figuring out smart workarounds for some of these barriers. Scrolling through the chat, some of these questions we've answered. I think we should all try Parachute and see how it works. And clearly it's worked better in some situations than others. Certainly some people are talking about how to check in with the pharmacy. So Shakara says, I'm new at doing prior authorizations. I use Cover My Med requests from pharmacies, but then it's not needed. How can we weed them out when we run into that without having to call the pharmacy? And I think one of our panelists said you just have to call the pharmacy. Does anyone else have any other answers? Seeing a lot of you just have to call the pharmacy.
I don't have a specific answer for that. However, some of the discussion did make me want to bring up one of the other changes in the new law, which is that insurers will have to have a website that states very specifically what they require for what needs a prior authorization, what the requirements they are looking for. Like, do you need to use this specific wording to get this covered? Instead of, it sounds a lot like oftentimes this is a moving target, shot in the dark kind of thing, and you're just hoping that you hit that trifecta that you need to. So one of the things we did do is really try and get it nailed down so that it would say very, very specifically what you need to cover in that request. Also, if they are going to be implementing a new prior auth requirement, if they are going to be making a change to a current one, if they are going to make a restriction on a current one, things like that, they have to provide that on the website with a certain amount of notice. And I'm trying to figure out, it was like 45 days or 60 days. And I'm sorry, I can't find it or remember exactly right now, but they would have to notify within that time period that, hey, this thing is going to be changing and you will now need to meet these requirements or whatever that may be. So hopefully that will help with some of these issues that you've all brought up.
Thank you so much. And Kate, again, thank you for being here. I'm going to switch over to CGMs. And so a couple of different comments. One, that Dexcom is more expensive. Not all insurances will provide, and they ask for co-insurance. Does anyone know how to find out which CGM is covered, whether it's Dexcom or not? And then along those same lines, some Medicaid plans seem to cover CGMs and others don't. I think, just as a spoiler alert, we're going to be looking into how to make it clearer which Medicaid plans require what. But any suggestions from our panelists about those two issues?
I guess I could speak to the Dexcom being more expensive. When it comes, like, again, a lot of our population in this particular office is Medicare patients, and therefore they bill the same code. So it's the exact same price for a patient to switch from Dexcom to, for the most part. I'm not sure if because they're coding the Dexcom until those 7s are out as 2, but I believe it's exactly the same or roughly the same. And then when it comes to commercial, if it's commercial and it's covered by as a pharmacy benefit, then that's going to be listed under their formulary guidelines where you'd be looking for any medication options as well. And so I use those formularies and the fingertip formularies for any commercial patients to look to see if there's an incentive for them to use one continuous glucose monitor over the other, just because it does save some time in educating them on a full system that they might not end up then using.
And then I would just throw in working with if you have relationships with the drug reps, I think oftentimes they're a great resource for CGMs. Anyone else have an answer to that question? Otherwise, I'll move along to another one. So last one for our time, can you bill for the time spent getting prior authorizations? And thank you to Erica, who is on the call, who is working on that in terms of care management, because I think that's probably the road to go. Does anyone have any other creative thoughts about billing for your time? Hearing none. I think it's a real challenge, right? So, really recognizing that this is a burden. I think, to Kate's points about the changes in the law, I think that is really the whole reason that this coalition pushed so hard to get this passed, that it is really difficult and a big burden on our teams and our time, given everything that we're expected to do. So we have about 2 minutes left. Any of our panelists left any of these other questions that I've left unanswered that you want to speak to? And I'll just pull out another question from Stephanie. Anything that supplements what we have in our resources? What are the patient's copays? Anyone have a great way to find out copays?
Just from my experience of looking into that, it's been really difficult to determine copays, because the way it sounds is that like every insurer who the employers like buy through, like Blue Cross or whatever, they have a lot of latitude to make those copays absolutely anything that they want, and they don't make that information widely available. And so it has been incredibly difficult, and insurers have been not really willing to share information at that level of detail. So that's been my experience with trying to find out copays at a more broad scale. I don't know if any of the panelists have had better luck, but that would be great if you had, because I would love to solve this problem too.
I'll just mention for Medicare patients, there is q1medicare.com, and I've not been able to find every plan that I've looked up on there, but most plans I've been able to find. There's a code at usually the bottom corner of the Medicare card, Part D card or Advantage card, but sometimes it's in a different corner. It starts with a letter, then 4 digits, then a space or a dash and 3 digits. And if you go to q1medicare.com, or just even put this into Google, Q1 comes up a lot of times first, you can access what's their deductible, and there's a link for the formulary, so you can see what's on formulary, and it will put the copays in there too. So maybe it's a 17% coinsurance. Most of the GLP-1s and SGLT2s that are covered are like between $43 and $47 for most of those Medicare plans. But that's what I use for my Medicare people.
All right, we are out of time. I'm going to hand it back to Jackie.
Just wanted to say thanks again to our panelists for joining us today, and Kate for joining us from MSMS. We really, really appreciate it. I wanted to also let you know that if you called in instead of joined like from a link on your computer, if you can email, if you're a physician who wants to get credit for attending this for your value-based reimbursement, I just would need you to send an email to the email that I'm putting in the chat right now. This is our admin assistant, Lifa's email, so that we can make sure that we track and capture your attendance here today. We can't do it if it's a phone call, so you just would need to email her and tell her you were there. Other than that, we're going to post this recording so that you can refer back to it and share it with others in your office who might be interested. And thank you again, everyone, for submitting questions, for taking the time to be here today, and just another huge thanks to our panelists.
Thank you. Really, really appreciate you. Thank you so much.
Thank you. Everyone has a great afternoon. Thanks. Bye.